All right. So I think in the interest of time and getting started by 10:55, I'm going to open this session. My name is Alex Tuttle. I'm a pediatric endocrinologist at Riley Children's Health in Indianapolis, Indiana, with Indiana University. Today, I'll be moderating this session on screening and early detection of diabetes. And without further ado, I'd like to introduce our first speaker, Abha Choudhary from Children's Health, UT Southwestern Medical Center. She'll be presenting on a single center experience of implementation of screening and staging of type 1 diabetes.
Hello, everybody. I'm Abha Choudhary. I'm a pediatric endocrinologist from Dallas, Texas. And I'm here on behalf of my multidisciplinary team. If I can get my slides. All right. So I'm here on behalf of my multidisciplinary team presenting our screening experience. My team consists of Lydia, who's our advanced practice nurse, Preeti, advanced practice nurse, Christina, who's a PA, Katie Hamilton, Marsha, our diabetes educators, and Don Buckingham is our QI coach. We joined the collaborative in September of 2023. Todd Alonso introduced us to the collaborative, and I'm glad we did. We follow a total of around 2,000 patients with type 1 diabetes. 43% are non-commercially insured, 82% are CGM users, 59% are pump users, and we admit around 250 new onsets per year. We have approximately 17 FTE faculty, and we are hiring. If you're interested in coming to Dallas, we have 3 fellows, 8.1 FTE APP, 17.5 FTE diabetes educators, RDs, 1.96, 5 social workers, and 2 psychologists. So this is jumping right into screening. So this is our fishbone diagram and interventions on what obstructs setting up early onset T1D screening clinic. It's a busy slide, but I'm going to try to hit the high points, starting with the upper right, patient staff. Knowledge was definitely a big bucket. Our intervention was education for staff, families, and PCPs. For staff, I created slide deck references and presentations. For families, we created handouts, which we handed out to them at every clinic visit. It was placed in our new onset binder, and it was a part of our monthly newsletter. For PCPs, that is still pretty challenging in terms of educating all the PCPs in the DFW area. We have created a podcast, which is live on our website, and we are in the process of developing these lunch and learn sessions and health equity kind of sessions. Lydia and Preeti are working on creating those sessions. So that is definitely work in progress. The other bucket is patient selection. So who is the right patient? Should we just screen siblings of T1D patients as recommended by ADA, or should we add on patients with other autoimmune conditions or people in the general population? The third bucket is appointment availability time, staffing, that whole big bucket. We, like other pediatric endocrinologists, are stretched pretty thin. Our next available appointment is in 8 months. So we had to be creative to see how we can accommodate these patients and see them in a timely manner. So we had to think about streamlining triage, developing clinic templates, and staffing for this clinic. Moving on to policies and process on the upper left, policy, we reviewed the guidelines suggested by ADA and ISPAD, looked at other centers for best practices, and developed monitoring protocols. In terms of processes, we developed a triage workflow, delineated who the personnel responsible is going to be, and created clinic slots. In terms of resources, we leaned on breakthrough T1D resources. We leaned on Sanofi, our partners who are here in the room, and we developed our own podcast, which is on our website. In terms of technology, we started thinking about labs. Is insurance going to cover these labs? And we were relying on external screening programs. So we are a TrialNet site, and what we typically used to do is hand out the TrialNet flyer to our patients and ask them to go get screened, but that did not really work well because when they got the kit, there was a large amount of blood needed from the finger stick. So we thought about setting up an in-person trial net clinic where patients can come in, get screened free of charge. We shared all this with our patients at community events and screening events as well. In terms of supplies and measures documentation, we thought about it right at the beginning. We documented T1D screening as the chief complaint on Epic so we can track the data. We developed a note template. For tracking, we developed a smart form on Epic, and so we can build reports on reporting workbench on Epic. In terms of monitoring and results, we tracked number of patients we screened, number of stage 2, and number of patients who received Tzield. Key driver diagram. So our aim was to increase screening of at-risk population from baseline to 15% over 1 year. And our at-risk population was defined as family members of patients with type 1 diabetes, individuals with other autoimmune conditions, and patients screened by PCPs. Key drivers were staff, patients, policies, processes, documentation, and tracking. And again, summarizing our interventions, education was a big one. Podcast, slide deck, handout, conferences, whatever we could do. Educate families at clinic visits, offer resources. Of course, buy-in from the team was extremely important. We reviewed guidelines, looked at best practices in other centers, looked at ISPAD monitoring protocol, triage guidelines, clinic slots, appointments, in-person trial net clinic. In terms of documentation, documented chief complaint as T1D screening so we can track the data, develop clinic note template and smart form on Epic. And in terms of tracking, build reports to track antibody status, whether it's negative, 1 antibody, stage 1, stage 2, and the number of patients we've infused Tzield. So this is our data. We started our screening clinic in end of September, October 2024, and we've showed a consistent increase in our screening numbers. So this is data through September 2025. In October 2025, we screened 26 patients. So our numbers are just going up, and we have been tracking patients who have 1 antibody, how many were in stage 1, stage 2, and stage 3. So since we started screening, we have picked up about 6 stage 2 and 2 stage 3 patients with T1D. More details on our PDSA cycles. So in September 2024, we reviewed the ADA ISPAD guidelines, I created educational slides and shared with the team. In October 2024, we started a screening clinic in our Dallas campus. We started off with 2 sessions per month, 4 slots each, so total of 8 slots. And it was staffed by our PA, Christina, with MD backup. So we created a Teams group where we had a team of MDs, PA, APP, diabetes educators, and ASR. There was a complete separate triage process for this, and the visit note template was being developed at that time. In December 2024, we started working on the Epic Smart Form revision so that we can track the data and metrics can be tracked. This takes a while, so we started this process early on. January, February, we started developing screening flyers for PCPs, and Preeti helped me with this. We also started educating our own children's PCPs in our network, and that is work in progress. In April 2025, we started a TrialNet in-person screening clinic in our Dallas campus, and this was once a month on 4th Tuesday in the evening. This was staffed by a research coordinator, absolutely free. Anybody can come and get tested as long as there's a positive family history. In June of 2025, our TrialNet screening flyer was approved by the IRB, and our screening podcast for the PCPs went live on our website. In July, August 2025, Leah, who's here in the audience, started her screening clinic at Plano campus. So Plano is our North campus. In September 2025, the TrialNet flyer made it to our clinic, made it to our new onset binder. The Epic Smart Form revision went live, and the one-page screening fact sheet for the PCPs went live. In October 2025, we've screened about 26 patients. We started our TrialNet in-person screening clinic, which is staffed by a research coordinator in our other campus, the Plano campus, and that's on the fourth Tuesday in the morning. So, like I said, anybody with a positive family history can just call, schedule an appointment, come in, can get tested free of charge. TrialNet flyer went out in our monthly newsletter to our patients, and we continued thinking about how should we educate our primary care. At Children's, we did some more talks for them. I also reached out to GI and encouraged them to screen their celiac patients. We are in the process of developing a lab order set, so it's easy for them to send labs to Quest LabCorp or to the Children's Lab. So future ideas, I have 3 other talks lined up. So I'm doing a breakthrough T1D event on Friday this week, which is going to be attended by 400 family medicine physicians to talk about screening. I have a grand rounds presentation at Children's in January of 2026, where a part of my talk is going to be dedicated to screening, and the audience is pediatricians and other specialists. T1D Detect has organized a summit in Dallas, and that's in March of 2026. I'm a part of the panel with an adult endocrinologist and a patient who's received Tzield, and we are going to have an audience of pediatricians and family medicine doctors. So more education coming there. Again, we are still working on educating PCPs, and we want targeted education to screen antibodies. So at this time, the patients we are getting are the ones who were screened for some reason, and they have elevated A1C. But some of the pediatricians are checking antibodies. So we really want them to check antibodies and then refer the positives to us. Another thing on the wish list is to develop an education curriculum for stage 1 and stage 2 for our diabetes educators and RDs. Psychology is the other big aspect, and we have to think through the screening tools for this population. And lastly, increase infusion capacity. We are infusing at our Plano campus. We do all 14 days as an outpatient infusion, and revenue is something we have not figured out. We know our hospital is making money on these infusions, but that is not really coming to endocrinology. So that's something I am working on. So this is an example of our documentation. We are on Epic. The left side shows the way we document. So chief complaint is labeled as screening for type 1. So that helps us pull all the data. Endo summary is on the right side, and that existed, but now we've added stage 1, stage 2, single antibody, antibody negative, date of screening, the reason for screening, if it's because there's this positive family history, positive autoimmune disease, other risk factors, or no high risk, and the treatment. So this way we are also tracking the number of patients who've received teplizumab, the date of infusion. The rest was the original endo summary, which includes which site they are at, if they're on a CGM, if they're on RPM, CAM status, scoping, etc. So this is our TrialNet in-person screening flyer, which we are handing out at every opportunity we get. So we had our breakthrough T1D walk last Saturday, and my research coordinator was there handing it out to patients. So anybody in the DFW area or outside can come and get screened in person, free of charge at both our campuses. This is the fact sheet we created for the PCPs, which is going to be live on our website next month. Just one 2-page document which kind of explains staging, screening, which labs to check, when to refer, and some of these CPT codes. Finally, going to end with our Tzield experience. So we've infused 5 kids so far. The first one was in 2023. The second one was in 2024. And since we started screening, we've had 3 stage 2s. We do midlines for all of these patients. We infuse them in our Plano campus. Side effects, typical side effects, fatigue for everybody, rash on day 5, low ALC count for almost all our patients which improved. We did not have to stop our infusion. We did not have any elevated liver enzymes or cytokine release syndrome. So since we've started placing CGMs on some of our kids, we've noticed that they get hyperglycemic up to the 300s on like day 7, day 8 of infusion, which lasts for a week after infusion, and then it settles down. One of our kiddos did go on to develop stage 3. That's all I have. Thank you for listening. Shout out to my Dallas Fort Worth team on the right side and the Sanofi team. Thank you, guys.
Okay, sorry, we have a very tight schedule. It sounds like we have 9 minutes per presentation and 4 minutes for questions. So I'll open up questions at the end if we have some extra time, okay? So next I'd like to introduce Dr. Laura Levin, who will be presenting about improving screening rates of patients at risk for type 1 diabetes in an academic institution with multiple providers and clinic sites.
All right. Thank you, everyone. I'm Laura Levin. I'm from Lurie Children's, and I'm going to be discussing our screening rates in patients in our institution. Okay, so to give a little background, which most of you all already know, but the reason why the project kind of started was to kind of prevent patients presenting in DKA. And so when we look at these patients, we want to kind of give them the opportunity to not get so sick and catch it before, they come in DKA, because that's the most common presenting sign. We also want to broaden the screen for type 1, and we can reduce the number of patients to identify those who are candidates for TZIELD. And we also kind of focused our efforts on individuals with a family history of type 1, obviously, or a personal autoimmune disease family history compared to the general population. And our project aimed to increase the rate of patients screened for type 1 by 15% from baseline over an 18-month period. So here's our fishbone diagram. And in our fishbone diagram, we first wanted to identify 4 key categories that were contributing to our low screening rates, because we were having issues initially with the project with screening. So we identified education, workflow, equipment, and equity. And then we went on to develop our key driver diagram. So from our key driver diagram, we identified those 4 causes, then developed secondary drivers. And from the secondary drivers, we were able to kind of decide what our interventions were going to be. And I'm going to go over that in a little bit. But as you can see, our interventions were derived to address both the secondary and primary drivers. So here's kind of our background of our institution. We have 8 clinical satellite sites, and typically at each of those sites, we have 1 to 2 providers at each site. So it's not like we have a comprehensive 5 providers at each site. We have a total of only 13 diabetes providers out of 28 providers total. And the time frame was from July 2024 to July 2025. So the interventions that we decided to focus on were, 1, we worked on education given to providers in our department regarding the rationale and process for screening during our monthly division meeting. So we were concerned because a lot of the providers who we work with don't all see diabetes patients. And so when we were kind of addressing this, we were like, we need to educate the other providers on why this is so important. The other intervention we did was we created prompts in our diabetes clinic flow sheet in the EMR to kind of address at the visit, talk to the families about screening. We also offered multiple screening options, including lab draw and enable kits. And we also discussed with families at the visit to say, should you bring in your other child, we compare the visit together with your type 1 patient so you don't have to kind of come in for a separate visit. We also hung informational posters displayed in clinic rooms to kind of raise patient awareness. So when families were sitting in their exam room, they saw this poster that kind of gave information about screening. So when we talk about barriers, I want to break it down into provider barriers as well as patient barriers. I think for us, the biggest barrier was provider buy-in. A lot of our providers, like I said, don't treat type 1 diabetes or type 2 diabetes. They do endocrine. And so in their eyes, they didn't really understand screening. They didn't know how to do it, and they were very overwhelmed by it. But once we kind of sat them down and provided a PowerPoint presentation to them and explained how to do it, I think they felt more comfortable with being open to the idea of talking to their patients about screening. The other concern that the providers expressed was, time. Will this take away from my visit? I don't want to talk about something else other than hypothyroidism. So that was another issue. But again, I think once we gave the education, a lot of our providers in our division were much more open to kind of talking about screening. From a patient barrier standpoint, before Tzield exists, I thought families were often very, weary, saying, this is going to cause me more anxiety. I don't want my other child to know. What do I do about it? But now with Tzield, I think we've kind of overcome that barrier and we're offering this to families. The other concern families expressed was additional costs, so financial burden, because taking them to extra appointments, the lab draw, all that was also a concern for these families when we talked a little bit about screening. And a lot of families were not even aware that Tzield was an option. Lastly, children under the age of 8, obviously right now are not, able to receive Tzield. So some of those families were like, I don't want to put my 2-year-old through the testing because if there's nothing to do about it. Here's our control chart. And as you can see, it starts from January 2024 to July 2025, and we see an upward shift in the mean screening rates after our initial intervention. So the baseline screening kind of starts from January 2024 to July 2024. And that initial intervention was first we did provider education, and right after we did the provider education, we did see an increase in screening. And then we tracked our other interventions, like I mentioned, the order set and Smartsheet. And furthermore, we did see kind of rates ebb and flow month to month, but we kind of nudged our colleagues and sent emails out to everyone saying, can you remember to screen? And once I kind of sent those emails out, like the next month, I'd see an uptick in screening again, but then I'd let it go for a couple months and we'd see a downward trend. So I think it was just kind of reminding my colleagues to, this is an option. Please offer your hypothyroid patients, this option. And we did see an upward shift. Okay, this slide was taken from the T1D exchange, and it's looking at the 4 participating centers. And as you can see, our screening rates are very high. However, to my surprise, our stage 2 identified patients were actually only 4 out of 282. So it was a low percentage. The other centers had a little bit of a higher rate of identifying the stage 2 patients. But when we look at the national percentage, I think ours is sort of in line with what they're seeing for those screens. So in terms of key takeaways from this project, I think, we have to kind of streamline our screening process. And we were able to do so through order sets, provider education, and also integrating it into the flow sheet, which those 3 interventions really did increase our screening rates substantially. I did find that the standardized order sets that we created, those are like a low effort, but high impact intervention. And we are starting to share that also with other community providers, other specialty clinics. So now that there's a whole order set, they don't have to ask us what they have to order. And hopefully that will generate more screening as well. And like I said before, I think the variability in the monthly screening rates was secondary to provider familiarity and reminding them to kind of do this because it wasn't on the forefront of their minds for a lot of the providers. And then the impact of expanded screening rates on patients who receive T1D, I think, is difficult to assess right now due to the low rates of autoantibody positivity in our screening rates at our institution. So we want to kind of continue screening, increase screening, and see the impact. So in terms of next steps, one of the things we're really working on is expanding to the community providers and other specialty clinics such as GI and rheumatology, and partnering with them to kind of talk to their patients, their celiac rheumatoid patients, about screening. Our goal is to establish a dedicated screening clinic, which we do not have as of now with our nurse practitioner, but we're working towards that. And then we also created a letter to all of our type 1 families kind of discussing screening and that their other children are eligible. And we're going to send that out actually in the next month. And hopefully all these efforts will continue to increase screening. Here's my acknowledgements, and thank you.
All right, awesome. Thank you, Dr. Levin. We have about 4 minutes to open up for questions now. Got 2 microphones, so I can try to run them around here.
Hi, I'm Grace Kim from Texas Children's. I'm not actively involved with our T1D screening, but a lot of our team is. I was just wondering, you said provider education. So I was just wondering, what are you educating? Like, if you have a patient with hypothyroid or any autoimmune, screen at one time, like what specifically are you asking them to do? If it's not like a family member with diabetes. Thank you.
So when I say When I said provider education, we talk to everyone who sees the patients for hypothyroidism, talking to them about saying, because you have hypothyroidism, you're at increased risk for other autoimmune conditions. And so now we are screening a lot of our other children for type 1. And same with the GI and celiac patients as well.
No, this is people on Zoom have to hear you, so that's why. Sorry. Sorry.
I was just wondering what your experience has been in terms of where you're ordering the tests. Like, we've been trying to figure out using like LabCorp diabetes autoimmune profile, and we just don't know what to tell patients in terms of coverage. I know it says it should be covered, or we've used Ask screening program in the past as well. I just didn't know what other centers were doing for that.
Sorry. For us, we're doing our Lurie Children's Lab, but we also have Enable kits in our clinic. And right now, Enable kits are free. They're running them at no cost. And that is a great option, I think, for a lot of families. We also do send them to Quest, and Quest is significantly cheaper.
Individual, or is there a profile?
They're at Quest. I think it's 3 in one group, and then you have to add the ZNT8, I think. I have an order set through Quest, though, too.
Sorry, my name is Carrie. I'm from UC Davis. I have a follow-up question in regards to what you just said. What is Enable Kids?
Okay, so Enable kits are, it's Enable Therapeutics, I think, or biosciences. And it has you poke the finger, you kind of dot on 3, I'm making it very simple. You dot on 3 little circles and you submit it back to them. And they actually give you your antibody results on 3 antibodies. So they don't have all 5, they have 3, but they state that their sensitivity is like 98%. And they just happened to give me a presentation, but they said that Quest, I don't know if this is accurate, is only about 50 or 60%, which surprised me.
Sorry, I have another follow-up question. There was a bug on me, so I guess that was somewhat of an emergency. Anyways, so it sounds, I guess I'm just trying to figure out logistically how you guys are doing things. So it sounds like you send people to the lab and you try to figure out some sort of payment situation, but then are you able to have like a clinic visit and not be able to bill, or are you able to bill successfully?
No, we bill for the clinic visit. We just pair it with so if a patient comes in with type 1 and they bring the sibling, we just make a separate visit type for that sibling and bill it.
Okay, and you guys are able to successfully do that?
Yeah.
Do we have any more time left?
We're out of time for this round. We can open it up at the end if we have time, okay? All right. Okay, so next I'm going to invite to the stage Trevon Wright with the Type 1 Diabetes Exchange. He's going to be presenting about operationalizing stage 1 and stage 2 type 1 diabetes screening, a multi-center quality improvement initiative.
Hey, hi everyone. No disclosures. Just a quick background. I know you guys have seen this slide probably more times than you can count, but we have over 60 centers at T1D Exchange, and we're using the data to really help improve the lives of those living with type 1 diabetes. And kind of the background of my presentation today, we know that T1D progresses to identifiable preclinical stages, but this initiative that we're doing aimed to improve early detection of stage 1 and stage 2. But in order to do that, we have to increase and enhance screening and monitoring efforts through educational coaches for endocrinology centers. The primary goal was to operationalize early stage T1D screening by using a quality improvement framework. For monitoring, individuals were eligible because they had confirmed stage 1 and stage 2 type 1. That means family history or program-specific criteria. But in order to really partake in this initiative, we really have to dig deep and see, why do we have so many barriers and gaps in this, right? We have over 60 centers, but there's not a lot of logistics on it, protocol procedures on it. So why is that? And just to go through the fishbone diagram quickly, because it's a lot. So for policies and procedures, there was a lot of consistency guidelines on who should be screened. And then for product and technology, there's a lack of point-of-care kits readily available in various clinical and patient locations. And then for equity, right, either health literacy or educational materials and communication for those who may not be speaking English. And then for place and process, outpatient settings, local risk outreach diabetes clinics. Sometimes centers just can't have any outreach because either bandwidth or they just don't have the resources to do that. And then for people and staffing, for the endocrine team member, sometimes this isn't mentioned enough, right? There's over workload, bandwidth, maybe lack of funding for FTE, lack of education as well. So we really wanted to dig deep more and really I think our next main step was we had 4 centers apply this initiative, and Dr. Levin's Lurie Children's Center is one of those centers, and Indiana University, Texas Children's, and Children's National. And we asked those centers to identify at least 3 strategies for screening implementation, best practice strategies for incorporating type 1 T1D screening in a clinical setting. The first one was patient engagement approaches, followed by workflow changes, overcoming systemic barriers and processes, and then documenting screening for stage 1 and stage 2 in the EMR, which is a lot easier said than done, as we all know. And one of those specific aims was increasing by 50% for those screened and an increase of 30% of those monitored. But in order to really understand, we wanted to do focus groups. There were 4 different focus groups that ranged from 45 to 60 minutes. And we really want to understand the experiences of these clinics, the workflow changes and barriers that they're facing on a day-to-day basis when it comes to screening implementation. A lot of the centers range from new program developers to those of the existing infrastructures. And some of the high-level findings that we found through these discussions were centers were building a completely new screening program from the ground up. So they didn't have an infrastructure that already existed. It was something that was started, pretty fresh. And then administrative and scheduling support varies by center, and it's crucial to continue success of screening and increase capacity, and then increase provider awareness and ensure that screening discussions are happening outside of the project team is very necessary. It's always great to have initiatives and projects, but if you don't have buy-in from your team, it's often hard to get results. And the majority of centers are documenting early stages of type 1 and type 2 diabetes. For the center that is not yet, they're documenting if the provider discussed screening with the family or patient. Some of the barriers included inconsistent provider involvement, documentation practices, EMR limitations, and tropicimab access challenges. And kind of the main reason for these focus groups as well is because I always ask, is it possible for a rural center in Montana, Oklahoma to take these initiatives and implement it in their center without seeking a significant amount of funding or resources to do so? And then some of the results here, centers reported that they dedicated clinic time expanding staffing, for example, for phlebotomists or CDCSs, EMR documentation tools, provider education significantly supported screening implementation, patient engagement materials, provider-facing dot phrases as well. And the new visit types were also developed too. Then the conclusion, we found that integrating early stage T1D screening into routine care is achievable through a structured QI support and educational support system. Clinical teams identified several best practices, strategies, and systemic obstacles, offering a foundation for broader implementation. And centers developed clear guidelines to determine who exactly will be screened, including specific criteria, who they will see in the clinic, a referral system, and also tracking tools as well. Then additionally, staff added a dedicated phlebotomist and more CDCSs to really support patients in this process and give them an understanding of the importance of screening and why it's necessary as well. And lastly, just references. Thank you.
All right, awesome. Now we will open up the floor for another 4 minutes of questions. All right. Yeah.
Hi, thank you. I'm Lorena. I have a question regarding teplizumab. How have you arranged the infrastructure to cover for weekend infusions and all of that?
Yes, I will give that to either Dr. Choudhary or Dr. Levin.
So we've set up the infusion center in our Plano campus, which just expanded. So we were lucky to have space there. And it is covered by nurses who do other infusions for rheumatology and GI. So they are very experienced. And this is 14 consecutive days, including the weekends. So they have provided us staffing for the weekends as well. Yeah. We've had 100% coverage so far, including a patient with Medicaid. I had to do peer-to-peer for 3 of my patients, 3 out of 5. But overall, we've had good coverage. This is for stage 2. If they meet criteria 2 or more with dysglycemia, we've received coverage. That's not a part of the original definition, so we don't use that. We use other modalities. So in the state of Texas, we were told, or maybe it's universal, but every insurance has their criteria. So if that insurance needs an OGTT, we've been doing that. We've started using CGMs lately, and we've been seeing some really high numbers on some of those. So, not to answer your question, not using CGM for dysglycemia.
Hello. All right. So again, we'll open up the end of the meeting for other questions if they arise, but we'll move on for right now. So next, I'll invite to the stage Lydia Hawley from Children's National Hospital, and she'll be talking about implementing an early stage workflow for stage 1 and stage 2 type 1 diabetes in a pediatric endocrinology clinic.
All right. Hello, everyone. My name is Lydia Hawley. I'm the clinical care coordinator at Children's National in Washington, D.C. And our team has been focused on bringing early screening, type 1 diabetes screening, into the day-to-day rhythm of our clinical flow, ensuring that it's accessible, sustainable, and meaningful for our families. Today, I'm going to walk through how we've designed and implemented a workflow to identify at-risk patients early, support our families through education, and create a consistent process for follow-up and treatment discussions. Let's see, I'm going to do it on here. There we go. Perfect. Our objectives, we'll quickly review the importance of early screening and staging. I'll outline the implementation of our two-pronged approach that consisted of education and workflow coordination. I'll review key outcomes from our first year of screening, and then lastly, identify next steps to continue our efforts. So why early screening matters. I'm not necessarily going to spend a whole bunch of time on the scientific reasons for why early screening matters, because I think that this room is well aware of the importance of early detection and staging, as well as recognizes the potential to change the trajectory of type 1 diabetes care. But what I do want to spend time talking about is what's always mattered the most to our team. And it's not necessarily been about giving our patients and families a test result. It's so much more about giving them time. So giving them time to understand what the results might mean, time to prepare emotionally, practically, time to learn about emerging options for monitoring intervention, and really just time to make a well-informed decision for their child and for their family. As we know, screening opens the door for education and support long before a crisis point. It helps families feel empowered instead of blindsided, and it also helps us build trust and a shared understanding from the inception of care. This philosophy of pairing clinical systems with meaningful patient engagement has always and continues to be the foundation for our approach to this implementation. So when we went to look at what we were working with, we did not necessarily have a whole lot going on. So we had no standardized process for identifying eligible patients. Our ordering was inconsistent. Our education varied by staff member, and many families were just completely unaware that screening was even an option. And so, of course, as a result, eligible patients were missed and our follow-up was fragmented. So when we sat down to design our goal, we chose not to focus just on increasing screening numbers, but to build a sustainable system. So one that connected education, workflows, and EMR tools to make early identification part of our normal clinic operations. Our project aim was then to establish a systematic antibody screening process to identify and monitor patients at risk for type 1 diabetes. We identified 4 main drivers: patient and family awareness, provider and staff engagement, and sustained workflows and policies that were supported by integrated EMR infrastructure. These drivers really gave us our roadmap, and from there, our work naturally evolved into 2 main focus areas, and that being education and the workflow coordination. Education addressed awareness and engagement, while workflow coordination ensured screening was built into the fabric of our clinic operations. On the education side, we developed clear, accessible materials explaining early stage type 1 diabetes and the purpose of antibody screening. We translated those into Spanish and Amharic, embedded those into our clinic touch points, such as our new AdSent binder, our triage area, et cetera, and we reinforced those in our educator and provider discussions. In parallel, we also hosted cross-disciplinary sessions to keep our providers, educators, admin staff, et cetera, informed and invested in the shared effort. On the workflow side, we created a structured process for both ordering and follow-up, and that meant EMR-based order sets, tracking tools, standardized follow-up sets for positive results. We defined exactly who does what, so who is ordering the screen, who's reviewing the results, and who's communicating next steps to our families. And this structure really helped make early screening more consistent and more sustainable across all of our providers. Since the start of this effort, we've screened 61 patients. Of those, 28 were antibody positive, 10 were stage 1, 11 were stage 2, 9 of which were eligible for Tzield. 5 of those patients ultimately received Tzield, and 1 unfortunately progressed to stage 3. The rest of our patients remain under active monitoring. Although our numbers may seem small, they are mighty. This first phase of our work was focused on building a reliable system and workflows. So the real outcome was consistency. Screening is now happening intentionally instead of incidentally. Our families are hearing about early screening and detection in clinic conversations. They're learning about what it means, and in some cases, they're assessing interventions that they might not have otherwise known about or thought were possible. So we still have much to learn, but have learned a good amount so far that we wanted to share. First of those being that champions drive change. So identifying a dedicated leader has really helped sustain momentum and accountability. We've also learned that patient-centered care is essential, and really just that each family's experience for readiness for screening is unique, and really just meeting them exactly where they're at. Education is foundational, so consistent and accessible information has empowered both families and staff. When folks understand why they're doing, why it matters, their engagement and follow-through improve. Equity requires intention, so tailoring our education and our communication through translation and expanded outreach were essential, not optional. Small changes really have created a big impact. So something as small as a standardized order set of a couple of labs has reduced variability and simplified the process, which in turn is increasing provider follow-through and use. And then finally, EMR-based workflows have reduced missed opportunities. So embedding those screening orders and the follow-up prompts directly into our EMR has shifted it from being a reminder-based process, which hinges on our providers, and instead just being a built-in automatic one. So as we look to the future and look for our next steps, we can hope to continue formalizing what we call our T1 delay clinic. And this is our structured pathway for antibody-positive patients to receive consistent follow-up and education and when appropriate treatment discussions. We're also expanding our multidisciplinary team to include psychology and nutrition into those early screening appointments so they can have that support there. Right from the get-go. Also hope to continue developing automated dashboards for ongoing data tracking. And finally, expanding our outreach to other specialty clinics. We've also partnered with our GI friends to screen celiac patients and look to do so with other specialty clinics, as well as going out into the community so we can reach more families upstream. With all of these efforts and our continued partnership with folks like yourselves, we hope to continue making early screening more than a test, but a chance to change the experience of diagnosis for our patients and our families. And with that, I thank you very much.
Hey, thank you, Lydia. I'll open the floor to questions.
Hi, my name is Isabella. I'm from Seattle Children's, and I also don't directly do the screening work, but I was curious for your T1 delay clinic, how often are you seeing them back, and what is the follow-up usually like? I'm sorry, I'm looking.
There. Amongst the crowd. Yes, no. Great question. So our T1 delay clinic right now is a bit ad hoc and very much personalized to the patients. For our patients who are identified as being stage 2, of course, we've got a really tailored follow-up system for them. For folks who it's maybe stage 1 or it's even like pre-stage, we'll put them into the routine 3-month follow-up or 6-month.
Any other questions? I know you had a question earlier. Did you still want to ask?
It was a comment, actually, rather than question. So Unable Bioscience, I used that for a long period of time. When I hear that free, I just feel like it's not completely free, but if that's true, let me know. I can talk to them why it's not free to us. But It's a free if it's covered by insurance, but if it's not, they say that it will charge them like about $50 or $70, something like that.
So I just met with them last week and they said that they're doing it's free no matter what. That's what they told me in Chicago. I don't know. Because they said that they're just collecting insurance, but even if you don't have insurance, she assured me that it was at no cost right now. That could change, but right now I can put you in touch with her.
That's a good to hear.
Yeah.
So thanks.
I apologize if I missed this at the beginning, but when you're reaching out to like catch your screening, did you talk at all about, are you guys also trying to screen like your celiac patients or your Hashimoto's or that sort of stuff as well? Thank you. Yes. So we just started this partnership with our GI folks, and they are right now just focusing on their celiac patients. They have a celiac clinic that they are targeting. And then, yes, it's very much our next step to talk to our endocrinologist friends who are in our team, just to, expand that outreach as well. Yeah. And our GI, I'll say too, our GI friends, they were really willing and super excited and eager. So it was just as simple as starting the conversation and answering their questions and spending some time with them. So it's been great.
So you mentioned that you are moving towards a more proactive model of screening rather than a reminder-based system. Can you expand a little bit more on how that looks like when somebody's checking into the clinic and how you're identifying people who need to be screened?
Thank you. Wonderful question. And I love too, I've been gathering some ideas. I love pairing the sibling appointment. So I think we're going to do some chart review. But one thing that we are really excited to get started on is actually putting myself more into clinic. So again, doing some chart review of patients who are coming in. And essentially, I will swoop in right after the appointment and say, hey, my name's Lydia. We're going to talk about early screening. Creating those touch points there as well, just to meet them right there while they're in the clinic. But we have to figure out the exact mechanisms of that. I'm thinking, again, chart review. I also love the idea of a newsletter. We've been wanting to do that for a really long time. The letters as well. I think that's great. So yeah, looking forward to it.
Also, can you say your name and your clinic affiliation as well for those on Zoom? Thank you.
I am Janice Wong from UCSF Pediatrics. For those of you who, I guess all of the speakers who had implemented in clinics, I guess the bigger question is how, I know you talked a lot about provider buy-in and really getting it integrated. Overall, and maybe it's a hard question to answer, like in all of the priorities that there are in clinics, how you've worked with leadership, how you've worked with both leadership and folks in your clinic who are doing the work to try to prioritize this, because I think this is a common struggle. It's like, well, we can barely get our current patients in, and this, again, when you look at the numbers, smaller, right? So how do you make that argument that this is important? And that goes for any of you.
Yeah, I'm curious. I'll pass the microphone so we can also chat with you guys too. We are very lucky in that our director of diabetes services is the one who's spearheading this effort. So that was easy to get that buy-in, but definitely a challenge. One of the big things that we focused on is the champion. So we have we have 3 providers who are our kind of go-tos and are really involved in this process, but definitely a struggle to get everyone involved.
Yeah, it's a great question. I would say that is our biggest struggle. We are more so focusing our efforts in the type 1 visits. So really targeting those families most. And then, the hypothyroid patients, sometimes they're quicker visits. So we kind of talk to our colleagues about saying 1 or 2 lines about quick, options to screen in a brief, 2-minute little spiel. And then if they say yes, then we can always do a telemedicine visit follow-up, talking more about the screening if families have more questions.
I'm the director of the diabetes program in my center. So I spearheaded this. I was the champion We were lucky to get two new, one PA and one nurse practitioner at the time we were talking about this, and they did not have a lot of things to do. So I said, you guys are going to do screening. So we were really lucky. And as our center started seeing money come in from TZL, they have been very supportive. So we got really lucky that way.
Thank you very much for all the great talks. I'm Marina Bassino from Stanford Adult, and I guess I have a question to all of you. Have you implemented or discussed with your adult colleagues whether the parents or adult siblings of the children are getting screened as well? Because I have a number of families that were parents diagnosed later in life, and they're even 70s when they have kids, when they were diagnosed as kids.
Okay, so our adult clinics are struggling with screening and TZL'd, and we've invited their family members to come to our site and get tested via TrialNet, but they have not figured it out. I think they're still trying to figure it out.
I was going to say at Riley Children's, we are fortunate right now that we have one of our TrialNet research team members coming into clinic and popping in after visits and asking about screening and monitoring, not just for the kids, but for the adults. And so that's been how we've been capturing more of adults, but also working with our adult colleagues to maybe get somebody who's a champion for early stage in the adult world.
We also have not really had too much partnership with the adult colleagues, and we're kind of focusing first on the pediatric and then hopefully expand.
Yeah, same with us. Sorry, I don't have any, but I love that idea. We have all sorts of QI projects going on, and transition clinic is a big thing that we're working on. So I love, maybe we're going to incorporate that in the discussion. Thank you.
Hi there. My name is Haley. I'm from Cincinnati Children's Hospital. And it's kind of a comment, but also a question. A lot of you have mentioned different strategies to getting these patients screened. And my question is, like, who is that right person to bring it up, and where is the right place to do it? Because I love the sibling combination. It makes sense. It's hard to get a patient to an appointment, but then that appointment could go longer, and then the burden is on that provider. But that provider has seen that child, hopefully consistently with continuity, and they have a relationship with that family. And then I also think PCPs really do have a place here, and like involving them in this. And, once again, like bringing it up with the family at a well child visit, like your child is healthy, but we know this is out there. So just thinking about other ways to get people in the door and get them screened, because I think there's multiple players that could be involved in this whole process.
Mark Moyed with SUNY Upstate. So we're a little lucky. I'm the adult side, but we are one floor. One side of the floor is pediatric, the other side of the floor is adult endocrinology. Getting patients in for screening is a little as a challenge for the adult side. What we're trying to do is to involve the primary care physicians more, where we essentially educate, and there's also these flyers that are available online that you can educate the primary care physicians, tell the patients to ask their primary care physicians for a set of tests, and that usually is quite successful.
Yeah, I agree. And I think we all probably agree of the PCPs definitely play a really big role in there. And I think that, bringing it up in the well child visit makes the most sense, or at least just mentioning that it's an option. I think the struggle, of course, is ensuring that the PCPs feel comfortable. I think that that's been our discussions with them. They don't feel like they know enough in order to answer all the questions. And, we try and reassure we're here to answer all the questions, and like let's partner and refer. But it's still, I don't know if we just still have like a ways to go. So we haven't quite figured that out, but yeah, it's definitely an opportunity there.
Yeah, I've talked with a lot of different PCPs. I think some feel more comfortable than others. And then kind of going with the barrier discussion too. Some PCPs feel like they have so much to cover at the well child visit that they don't have time to kind of bring this up. But we're trying to encourage them and trying to talk to them about quickly, talking to the families. We're going out maybe and giving some education as well to the PCPs so they feel more comfortable. And like I said, we created an order set that they can use that can be helpful.
But what seems to work is if the patient walks in and says, I want this.
Yeah.
Primary care physicians oftentimes lower burden would be just to give in and do it, as opposed to have a discussion why they don't want to do it.
I was just going to comment that there's almost too many options for screening, which also provides a layer of confusion for primary care physicians on where to send individuals to screen. If your institution does, initial provider visits through telehealth or something to talk about screening, I think Texas Children's is doing that, and that seems like a really great setup. But I know at Riley, we just don't have the bandwidth to have somebody dedicated to offering a telehealth visit just to discuss screening options. So I think everybody's resources are different in how you do that.
One thing I want to mention that we haven't yet got started on yet, but we're really excited to. We have Children's National also serves the DC Public Schools nursing staff. So we have a really great partnership with the schools. And we have 2 folks on our staff who are really invested in this work and partnership with schools. And we're going to start introducing the conversation there as well. And trying to, again, we've just started, so we aren't sure how we're going to start getting the word out, but if it's engaging the school nurses, if it's including it in some sort of binder that goes home with kids or on bulletin boards or something of the sort, so that, because totally agree, I think that having patients and families go into the PCP visit and say, hey, I've heard about this, I want to learn a little bit more, what can I do about it, would be great. So we're excited to get started on that.
I have Patty Henley from New Orleans, Delaware. One question and then 2 comments. The first comment is I think we still get a lot of pushback from providers in clinic with the only option being Tzield. I know everyone's excited about Tzield. It's the only thing we have, but the 14-day infusion, all the barriers. As there are more stage 2 trials, so 26, there's going to be a JAK kinase inhibitor. And I think we're at the breaking point where we're going to see more and more. I don't think Tzield is going to be it. I think you'll also get more buy-in from your endocrine providers, because a lot of people, when we started to do a pilot, was, well, what options do we have besides that? And knowing that those are there is an option. The other comment is, I think, on antibody screening and all the options causing confusion and the differences in validity in the test. And I think it's something that as a group is worth it exploring in the future. So whether you're doing ECL at Barbara Davis or whether you're doing ELISA with Quest or LabCorp, they are different. And I have patients that have had positives at LabCorp, normal on TrialNet, and normal on Barbara Davis. So, those kind of things just as a bigger group. Right now, obviously, the goal is just to get the screening done, but I think that's something that will be a big effort in the future. And then the last thing is a question. So you guys, meaning DC Children's, about 50% of the people you screened were positive for antibodies and about 10% got Tzield. I know it was 5 out of 61. So what was different about your cohort as opposed to just luck compared to Chicago, where I don't remember from the beginning of your presentation, but seeing that, I mean, more than almost half of your patients had positive antibodies. So was there something specific, or obviously just luck of the draw maybe over time, but about who you screened? Because if we all did that screening, we'd be really happy with those results.
Yeah, thank you for that question. I think, again, our this first phase of our effort was, focused on just making it really consistent. And so our cohort of kids that were coming in from referrals, so hadn't yet necessarily really broadened our screening effort. So I think now, with these next steps that we're going to be taking, are really curious to see just kind of, the range of kids that we'll see. I don't know.
Okay, we got a question from Zoom.
For those that are partnering with GI and rheumatology or screening with autoimmune hypothyroidism, where are you getting the autoantibody testing done if there's no family history of T1D? Are you charging insurance? And is there payer coverage for it?
We've been sending it to Quest LabCorp or our children's lab. I have not heard of any insurance issues so far.
We have as well. We also send them either to Lurie or Quest or LabCorp as well. And we've had no pushback. I've had no pushback as well from any financial concerns.
Any other questions?
All right. So I think that concludes our session then. And you got 10 minutes back to your schedule. Thank you, everyone.